My title is Alternative Payment Models. We're paying for value, not just for volume. And I think that's the underlying opening premise here, is that a lot of the problems in our healthcare system are caused by the way we get paid. And I'm a pediatrician, so I'll tell you, I get paid by the visit. I get paid for every procedure I do. And so the more procedures I do, the more revenue I generate for the system. And that's generally true throughout all of our systems for the last 100 years, that providers, whether it's a hospital or a doctor, or an MRI center or anything else, they get paid. The more things they do, the more they get paid. And we call that paying for volume. Next slide, please. So our idea is that if we want to change the way we practice, because when you get paid for volume, what that incentivizes you to do is see more volume. So the complaints we get from patients are that we're trying to see too many patients and we're making our visits shorter so that we can see more volume and things like that. So if we change the way we get paid, then we will drive changes in practice. That's the big idea. And so the big idea is that we need to pay for value, not just for volume. And as was pointed out by a doc about 10 years ago, Paul Grundy, if you're going to regulate something complicated, you need a lot of dials. Right now, our only dial is volume. If we want more money, we want to increase the revenue, then we add more volume. If we have enough revenue, we decrease volume. And that's pretty much what we do. And so he has this little image of, a control panel that I like to use. But the way we think of value-based payments is these are the dials that we're going to use to try to change the way the healthcare system works. Next slide. So what do we mean by paying for value? And this has been the subject of a lot of thought over the last decade. And there's a group called the HCPLAN, which I am not going to tell you what it stands for because I get it wrong every time I say it. But it's a group of people who pay for healthcare, and a group of people, and along with folks who provide healthcare, who've gotten together and tried to define what the different categories of these different alternative models of payment could look like. And they've set it up into 4 big buckets, and each of those buckets has some small buckets within it. I'm just going to describe the 4 big buckets, and if you want to know more, I'm happy to. There's a link at the bottom where you can look it up. So category 1 is the way that we currently get paid, fee for service, no link to quality and value. Category 2 is when you are linking that payment to some measure of quality and value. And that's sort of the first level of alternative payment models. Then there's category 3, where you are building this new kind of architecture onto a fee-for-service system where you're still getting some of your money by getting paid fee-for-service, but you're also generating payments because you're able to manage either a condition or a population or something better than other folks do. And category 4 is what they call population-based payments. Let me go into each of those a little bit in the next few slides. Next slide, please. So here's the classic fee-for-service payment system. Physician performs a service, we code the service, we put that code onto a bill that gets sent to your insurance company. The patient pays a little bit, the insurance company pays more of that bill, and how much they pay is based on those codes. So as a provider, what do I need to do to be able to make that system work? I need to be able to code well, and I need to have adequate volume. And so if I see a problem with how I'm getting paid, what I do is I look at my coding, and that's happened a number of times. People spend a lot of time looking at that, trying to figure out, am I coding properly to get paid for what I'm actually doing? And or I try to find ways to add more volume to my business. And that's pretty much what you can do is, as a business person within medicine, to try and increase your revenue stream. Next. What do we mean by linking it to quality and value? So there, the provider performs a service, they code the service just like they did before, and all of those things happen, except when the payment comes, some part of that payment is based on how you performed, based on some sort of quality or value metric. And that's where we get into this whole notion of measuring quality. Now, the picture next to it is a practice I worked with in Rhode Island that had moved to a value-based payment system. And they were touting themselves as being the medical home. They were going to take care of you in a way that's different than someone who's just trying to see you for an individual visit. And that's requires you as a practice to understand what do we mean by measuring quality and how do we improve the quality of care that we have. You have to have a system in place to be able to improve quality of care. And so that's the first category. And that actually works reasonably well. If you start telling people, if you start grading physicians on their quality, we're all A students, we all want to do well. And so we'll start doing things differently and better. Next category. So then we have this thing called the APMs built on fee-for-service architecture. And I apologize if this is unclear because this is the one that is hardest for me to understand. What they do here is all the same things that you do in the previous system, except at the end, the insurer, the payer, and the provider look at how much money they may have saved in the system, and they split it, and they share in what savings they've been able to generate by eliminating waste within the system. And that requires you to move on to something called managing population health. That's the new component that we want practices to add to be able to do that. And that means they need to be able to identify a population. They need to be able to look at the data on the health of that population. They may need to come up with some way to reach out to that population who's not necessarily showing up in their offices. They need to have collaborators in the community to help them do that. It's really a restructuring of how you do your practice, and it's the beginning of that. And it's a big deal. And I would say when Trevor Arbeta talks later, he's going to tell you what Medicaid is doing. And this is where Medicaid's system sort of fits right now, is into this sort of transitional stage where we're trying to figure out how do we get some of the waste out of the system, and then what do we do with the benefit of that, of eliminating that waste. Next slide. The final category is what they call population-based payments. Now, this you've probably heard of. This is popularly called capitation and involves getting paid, told that, assigned a population of people that you're covering and providing services to that population. And then you know how much money you have, and you get to manage that money, and you need to be able to determine that you have enough money to manage the population you're taking care of. The key in here, the key new skill in addition to managing population health, is that you need to know how to manage risk in this population. You're actually taking a lot of the risk. If you guess wrong and don't have enough money in the bank, you're the one who takes the loss. And so this is really the hardest of those categories, I think, to manage. Next slide, please. As always, the devil is in the details. And one of my colleagues on the Primary Care Payment Reform Collaborative, Stephanie Gold, put together a nice sort of critique of all of these different models. What are the problems in all of these things? And in this nice table she put together for us a couple of years ago for the Primary Care Payment Reform Collaborative. And as you can see, when we're in a traditional capitation model, you don't have much of an incentive to take on complicated patients because those are the ones that are hard to predict how much money you're going to need. Also, for all of these, basing how much you're getting paid based on prior payments for primary care kind of locks us into a system where primary care didn't get very much money, and all of them have that problem. So none of these things are perfect, and you can find lots of critiques about whether these alternative payment models work or not in the literature. But I will tell you that the ones that have worked, I think, are the ones that focus primarily on the quality of their performance rather than on the financial management aspects of this over time. So hopefully these new systems will move us in that way. Now, I said I would give this talk if they let me make one more point, because I'm a pediatrician. A lot of the programs, and Trevor's laughing because he's heard me say this way, and Tara have heard me say this way too many times. For a lot of these programs, as I said, eventually move to the point where the key to managing them is the elimination of waste. And the good news about the care of children is that it's relatively inexpensive and that we don't have as much waste to get rid of as our colleagues in the adult world do. And so there are problems with trying to design these kind of payments in the pediatric population. We have A lot of the stuff in the adult population is based on the management of chronic disease. The good news is that most children don't have chronic disease, as opposed to most adults like me who have 3 chronic diseases. So, it becomes harder to design those systems. Kids are incredibly susceptible to social conditions. And so in addition to being able to adjust for the medical risks, which we do in the adult population, we need to know how to adjust for social risks for kids. And that's much harder. And there's probably less waste. So there's less waste that you can convert into payment, which is kind of the premise of a lot of the systems we heard before. So I'll end with that thought. And then now that I've been talking health economics at you for 10 minutes, I'm going to let you stare at a beautiful sunset from Mount Evans before we move on to the next speaker. Thanks very much.